Hi, I'm Jim Cashel. I am here with Stephen Shortell, the Dean of the School of Public Health at the University of California, Berkeley. And Dr. Shortell gave a presentation about the balance between quality and cost. And when you read those two terms in the same sentence, you automatically think, can you do both? Or are they automatically opposed to one another? How do you achieve both cost and quality in health reform?
The key is really value, which really brings together the quality and cost components. And so what we would like to do is for all the money we're investing in healthcare here in the United States is get more for the money we're investing. And we also believe by eliminating some of the rework, the waste, the errors, and so forth, that we can begin to moderate to some extent the growth of costs over time. So what we're trying to do is find insurance coverage to expand that to all Americans. But you can't do that without working on the delivery system. And working on the delivery system is difficult work, but there are a lot of ideas floating around now on how we can maintain quality at lower cost or additional quality increments at less cost than it would cost us otherwise.
So you spent quite a bit of time talking about accountable care organizations, yes. ACOs. Can you say a few words about that concept?
Yes, accountable care organizations are accountable care systems, but in Washington we're using the term accountable care organizations. ACOs are basically practice entities, groups of hospitals and doctors, they could include nursing homes, that in essence are responsible clinically and fiscally for all of the care that a given group of patients receives. And they will have the ability to generate the data where you can fix that accountability. And for those that become a part of accountable care organizations, they will be offered financial incentives to share in the savings if they can deliver that care under projected spending for a given population. And again, meeting certain appropriateness criteria and quality criteria as well. So it really offers physicians and hospitals in the United States, some of them a different way of kind of organizing to be able to respond to some of the incentives.
So there are many Hill staffers, as we speak, busily scurrying around writing legislation, debating these issues for some major legislation that will be coming out in the next number of weeks, really. What do you expect either for accountable care organizations or general approach to balancing quality and costs in that legislation?
ACOs are very much a part of the discussion, the legislation that's occurring now in Washington, and they're being written in particular for the Medicare population. The idea is to start off with some demonstrations or some pilots in certain areas of the country and offer physicians and hospitals choices of how they might come together under these ACOs. Some might be physician hospital organizations, some might be what we call interdependent physician organizations that develop the leadership and the infrastructure to be able to generate the cost and quality data and qualify for some of the savings and so on. Some will be multi-specialty group practices. And so it's very much a part of what we see coming out of the BACAs, out of the Senate, will be incorporated, and it will begin to roll out, we think, in demonstrations for a year or two and see what works before they might be extended to the rest of the country. We're going to offer doctors choices. I mean, they don't have to join an ACO, in which case they'll be subject to the current Medicare payment, et cetera, et cetera. The incentive to join the ACO is to qualify for additional income and additional quality bonuses and so forth if you do become, and if you're able to perform. There could also be a downside risk as well if you're not. So this is being talked about in Washington. On other fronts, very much talking about bundled payment for certain hospital procedures in which we're trying to create common economic incentives for hospitals and physicians to work together rather than now where they get funded separately in silos. It's expensive. We have preventable readmissions. There's about 18% of Medicare discharges now end up being readmitted to the hospital. The estimate is up to half of those could probably be prevented. And if we could do that, it would save an estimated $12 billion. So we're trying to create financial incentives, different ways of paying other than fee-for-service, that will give common incentives for hospitals and doctors to work more effectively together in managing patient care. Another idea being talked about is episodic care-based payment, similar to bundled payment in many ways, but it covers a lot of care across the entire continuum, and that's being talked about as well. And basically we'll probably end up with a portfolio of different approaches to payment that will include perhaps still some fee-for-service in some cases. Another idea, of course, is to pay primary care physicians a little bit more money, taking responsibility to be the care coordinator for patients over the entire continuum of care as well, and getting more money for primary care and offering that as an inducement, hopefully to get more people to go into primary care over time. So all of these are being talked about, and then in addition, as you know, the president has allocated 19 to 20 billion for electronic health records.
Right.
And this is a tool that's going to help some of this performance measurement occur. My own concern is that too much of that is going to go to hardware and software,
Right.
and not enough to the technical assistance, the tough work redesign work that needs to be done before you use the electronic health record. That, after all, is just a tool. So I'm hopeful, and we've been trying to advise Washington to put aside more of that money to provide technical assistance and support for doctors and hospitals to kind of redesign care and not just use it all for simply adopting hardware and software.
Right. Well, Dean Shortell, thank you very much for your
John.
insights.
Okay, great.